Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi everyone, thanks for joining me tonight. I'm super excited about tonight's show. If you didn't see the title of tonight's show yet, just wait. The title of tonight's show is Fertility Sexting, a handy guide to fertility abbreviations. So if you're a fertility patient, you've gone on message boards, you've gone on blogs, and you've gone into chat rooms, and you can see all the abbreviations that people use, whether it's AMH, FSH, IVF, 5D, 8D5PT. There are so many abbreviations out there. So I thought it would be really fun to give my version of what I'm calling fertility sexting as a sort of fertility glossary for you guys tonight. And it didn't come from nowhere, but I'll tell you where it originated from in a second. So in case you missed it, there's some pretty cool fertility news this week that everyone's been chattering about. One of the oldest frozen embryos was thawed, and the baby was born last month. That's pretty amazing. So this embryo was over 20 years old. And patients ask me all the time. They say, Amy, how long can my embryos be frozen for? And I constantly tell people not to worry, there's no such thing as freeze or burn. As long as human beings exist, and they certainly do, that have the technology and the know-how to thaw an embryo, then you can certainly feel really comfortable that there shouldn't be any rush or emergency to freeze and then thaw your embryo in a really short period of time. I've had patients who I've seen in 2008. I've been in practice now in my office here right outside San Francisco for almost 10 years, and they've come to me after all this time to have another baby 10 years later, and their transfers have gone beautifully, and their embryos, once thawed, look just as fresh as if they were just frozen. So it's pretty remarkable technology. And I'm also pointing at these lovely earrings today that I got as a gift. They were a gift today, and I have a feeling they might be watching, from patients of mine who went through 4 IVF cycles before they achieved their success. Their 4th one was with me, and they brought in their adorable baby today to say hi. And so I'm wearing these earrings because they mean something a lot to me. They're quite special to me. They're crystal hearts. So thank you guys for coming for the visit, and thank you for the gift. So this is where fertility sexting actually came from. So this is what I do when I wake up in the morning. I just sit in bed and I say, coffee. I wonder if coffee's gonna come. And so sometimes I go over to my phone and I text to my husband and I say, you up? Because sometimes he's not there because he's already up, and I texted him, you up? And his reply was, is this a come on? Are you sexting me? And I didn't even think about that. I thought that was very funny. And then I just basically said I fertility sex all day long, because patients are always asking me questions, and they're asking me, can I have sex? When can I have sex? Can I have sex now? How about tonight, tomorrow? How many times? So I thought there's no better time to do a fertility sexting show than tonight. So snuggle up, let's talk. And I'm going to talk to you about the first fertility glossary term that I want every fertility patient to know, okay? But before I do that, I want to tell you why I started the Egg Whisperer show. I started this show in 2017 because basically I felt like there just wasn't enough accurate information for people. I want people to feel empowered. I want them to know that there are tests that they can do, that when you're a fertility patient, you don't just go with your gut. You can actually access diagnostic tests to kind of inform what's going on, and based on that information, what you should be considering as far as what will give you the best chance for your future family. I want to do that with a human touch and provide people emotional support, and at the same time let people know that no matter where they are in their fertility journey, that I want you to remain hopeful, and that my mantra is success is around the corner, and you're going to have a baby one way or another. So let's talk about my first fertility glossary term. So the first one is very simple. It's MD, right? So I have a picture here of, it looks like a church, and that's because with all the signs that we read about, for example, this year it was the first delivery from a uterine transplant. I mean, that's pretty amazing. An embryo that was frozen for over 20 years. You would think that IVF success rates would be 100%. And I just get this sense that people, when they walk into a fertility clinic, a lot of times they think that MD means medical deity. So I just want to remind everyone that MD means medical doctor, and we're just people, and we're people dealing with human biology. So it's so important to go with your gut. Ask questions. Always ask, what am I doing? What am I doing it? What's my diagnosis? How will this help? What else can I be doing to make things even better? So MD equals medical doctor. We're not God, far from it. God doesn't work in my office. Sometimes I feel like I should put a sign at the front door. I don't take credit for the success stories that come out of my office. I celebrate them. And at the same time, I know that when a patient isn't successful, that we've done everything possible to give them their very best chance for pregnancy. Okay, so the other thing, when you walk through my door, and I can't take credit for this fertility glossary term, okay? It's infertility, but it's not the way you think about it. It's you are in fertility. Get it? Okay, here's stay with me for a minute. So when I see a patient walk through my door, and they're coming in with all these levels, they're thinking that their FSH is high, their AMH is low, and they have DOR, we'll talk about that in a second. They're feeling like they're not fertile. But when you walk into my door, I see you as a fertile person, someone who's going to be successful, someone who's going to be a parent. So rather than use the word infertility, as if you are not going to get pregnant, think of it as I am in fertility. So I'm definitely in fertility because this is what I do. But I see all my patients as fertility patients. I don't see them as not fertile people. Very important fertility term or glossary term for everyone to kind of know, think about, and then just take the other term out of your vocabulary, if at all possible. Next term is FSH. So FSH, what it really stands for is follicle stimulating hormone. So FSH is a hormone secreted by the brain, okay? It talks to our ovaries. It tells your ovary to make a follicle, and usually it's one follicle that has one egg that's ovulated every single month. We check FSH hormone at the beginning of the cycle, usually between cycle days 1 through 4, and you can very simply go to Google and put in FSH over the menstrual cycle, and you'll see what happens during the menstrual cycle and what happens around ovulation. The reason why we check FSH at the very beginning of the cycle and not at any other time, because we use it as a diagnostic tool. And the term day 3 simply comes from the fact that when you do research studies, you have to standardize this kind of testing so that it's constant and the same day for everybody. But you can interpret the levels about the same way, whether it's cycle day 1, 2, 3, or even 4. So what I find people do is they take these levels and then they feel like this level defines them, or it might say things that may be more reassuring than they really are. And I'll use the word false security hormone. So that's actually how I think about it. I have patients that come in, they're 50 years old, and they say, my doctor told me I have the FSH of a 25-year-old. Well, the thing is that we don't just look at FSH. We look at FSH with estradiol. So when the estradiol is low, it means that FSH is probably a true predictor of what's going on with your egg quality, potentially. We'll talk a little bit more about that in a second. When your estrogen level is high, it means that the FSH is masking your true, the estradiol is masking your true FSH level. So when your estrogen is high, it comes from the ovary. It reduces your FSH level. I'll give you an example. Let's say your FSH level came back at 5, your estradiol level came back at 110. What that tells me is that your true FSH is probably a little bit higher, or you actually have a cyst on your ovary. So how do you know what the difference is? Well, before you start getting worried or panicked or anything like that, you simply do another test. Next month, feels like forever, you do another FSH estradiol level together, and then you kind of see what's going on. So based on your age, your follicle count, your AMH, and what your doctor knows about you, you guys can develop a plan and talk about what makes the most sense for you and what these FSH levels represent for you, for your egg quality, and what you should be thinking as far as treatment. These are just diagnostic tools. You can't take anything that really changes the level in any meaningful way, and what I mean by that is this. You can certainly take hormones that will adjust the FSH. For example, there are Chinese herbs that can affect your FSH level. There are hormones like birth control pills, estrogen pills, that can also affect the FSH level. But the FSH represents, just like I said, it's a diagnostic tool. It's kind of like just getting a glucose level and seeing if you have diabetes in just that one snapshot of time. So the next fertility glossary term is AMH. To me, that's always meandering hormone. For most people, it's pretty constant through the cycle. For some people, it actually may fluctuate. For some people, depending on your body size, it may also be falsely suppressed. For other people, if your vitamin D level is low, it also could be suppressed. So it might not be a true representation of what's going on with your egg quality. Same with if you're taking birth control pills. The other thing is, I'll give you an example. If you have it tested at 2 different labs or it's handled in a different way, potentially you can have a level 1 year that's, I'll give you an example, 0.5. And then the next year it's 0.7. So if you see that change, one might think, oh my goodness, my egg count went up and my egg quality got better. But the reality is it's probably about the same, and last year it probably was a little bit higher, and this year it's still probably a little bit lower, but overall it's a hormone that always meanders. So checking it, getting worried about it, don't worry, is basically what I'm trying to say. Just believe and know that it literally just takes one egg, one golden egg to have a baby, and the fact that your AMH is detectable in and of itself means that you could have a good egg left. So rather than worrying about what you can do to change these levels, and what I tell people is these are the kinds of things that are not in our control. The only thing that's in our control is our lifestyle, our health habits, and doing whatever we can do to reduce stress and live the healthiest life ever. So the next fertility glossary term is something that I see a lot, and the reason is because most of my patients are over 39. DOR stands for decreased ovarian reserve. It's actually quite normal to have low fertility levels, which means a higher FSH and a low AMH for any woman over the age of 40. So when women come in and I see that their levels are normal for a 40-year-old, I say your levels are perfectly normal. They're normal for your age, and this is what they suggest for your fertility. And as a fertility provider of women who are also over the age of 43, I have the ability to kind of guide people and say, based on my experience, for example, if I see someone who's 44 or 45, I can say, you know, the other women who've been successful at your age, they've either had the same numbers as you or different, and then I'll give them a calculation as far as what I think their pregnancy rates are, and then we can decide what makes sense for us to do next. So DOR doesn't mean react, it means don't overreact to me, okay? And the other thing that DOR means to me is it does not mean donor. So one of the things people do is they go online and they read about DOR and they all of a sudden feel like they can't use their own eggs. Well, I'm the first one to tell you I have so many patients who have this diagnosis, and I don't think of it as donor. I just think of it as an opportunity to help people as soon as I meet them. And I tell my patients to consider being as aggressive as you are willing to be and just keep showing up and take advantage of each cycle, and you never know when you're going to ovulate your golden egg. So the next one I thought was really fun, and that's IUI. So a lot of guys come in and they just, you know, with their partners, and they ask me, well, what's IUI? And I usually used to say, well, it's turkey baster, and they usually just nod their heads and are like, okay, that makes sense to me. Or I could say, it's up inside. So that's another way of thinking of IUI, or intrauterine insemination. And the thing about IUI, I think a lot of people think it's a lot more powerful than it really is, as if we have the ability to actually, you know, take the best swimmers and put them at the top. Actually, what we're doing is just we're removing semen, and we're removing white blood cells and bacteria cells by putting the sperm through a special wash, and then taking the motile sperm cells, but sometimes it's not just the motile sperm, it's not just the good sperm, the bad sperm go there too, and then we deliver all the sperm to the top of the uterus. So there really isn't as much of a selection process that people think that there is. However, by giving the sperm that head start, they're going to have a better chance at basically penetrating and fertilizing the egg. So what I tell people, it's kind of like that show Wipeout. You know that show where you have the human person going through that obstacle course where they have these big balls coming at them back and forth, and I did just say balls, and I think I'm way funnier than probably you guys do out there. But think of a little sperm cell that's microscopic, and it's trying to go through all the nooks and crannies, through the vagina, up into the uterus and into the fallopian tubes, and it's trying to get to the very, very top. So by delivering the sperm and taking them basically, 7 centimeters closer to the egg versus 7 centimeters further from the egg, hopefully we're giving that sperm a better chance at surviving and penetrating and fertilizing the egg. So the next one I thought this was pretty clever, is for something called ICSI. I'm just trying to turn my computer on to see if I have any Facebook questions at the same time. And so what ICSI stands for is I'm certain sperms inside the egg. So ICSI stands for intracytoplasmic sperm injection. That's a very big word to be saying over and over and over. So think of it as I'm certain sperms inside. Because when you don't do ICSI, you're just taking an egg and putting a droplet of sperm on top, and you're hoping and praying that 100,000 sperm cells, maybe one, will be able to get in. So if you're someone who's done multiple IUIs, you could actually have a fertilization issue that's either egg or sperm driven. So by doing ICSI, you're going to be certain that sperm's inside the egg. I certainly have had patients that have said, I really want survival of the fittest, I want the best sperm to make it, and that's totally fine. But sometimes when you do that, you may end up with less normally fertilized eggs. It's just really, really important to talk to your doctor, talk to your doctor about what the lab's experience is with a situation just like yours, and see what's going to give you the best chance to have as many fertilized eggs as possible if that's something that you want to do. So the next thing to talk about is PGS, and that stands for pre-implantation genetic screening. So that's a process that we put embryos through. It involves an embryo biopsy, and we take those cells and we send them to a genetic testing lab to be analyzed. So imagine you're a person and you have a mole and you need it biopsied. You're going to go to the dermatologist's office, they're going to take the biopsy, and then you're going to go home, but that biopsy is going to get sent to a center or pathology lab to be analyzed. So that's basically what happens to embryos. They get frozen, they stay in the lab, the cells get sent off to be analyzed. But once they get analyzed, those cells don't need to come back because those cells regenerate at that area of the biopsy. Okay? So PGS to me means pretty good science. It's not 100%. Okay? So what does that mean? It means that if an embryo is normal, there is a very small chance that there could still be an abnormality. An embryo is microscopic. It doesn't have as many cells as, let's say, a growing embryo or closer to a fetus. So there have been cases where a patient transfers a normal embryo and still miscarries, and then we find out later that that embryo had some level of mosaicism. The other thing is this concept of mosaicism. So what that means is I'm not saying there's a chance that that embryo could be normal, but what I'm saying is you need to talk to your doctor about whether they'll report mosaic embryos, and you need to talk to your doctor about what that means for you, for that chromosome, and if you should still give that embryo a chance. So for my patients, I talk to them about their embryology report. I give them information so that they can talk to the genetic counselor about what the report means. So they get basically another opinion for someone else, another type of scientist who can talk to them in a different way. So when you do PGS, people think that it looks at everything. PGS only looks at chromosomes. It doesn't look at diseases. It doesn't screen out things that a lot of people think it might screen out. So make sure that you know it's basically pretty good science. It's not perfect. We haven't gotten to the perfect platform where we can really see everything in an embryo, things related to whether an embryo will really implant or miscarry. I mean, those are the kinds of things that I would love to know, because the hardest thing you can imagine for a fertility doctor is sharing bad news with patients or doing an ultrasound where you think everything's going to be great and then you learn that everything's not great, especially when you've gone through pretty good science, which is PGS, and it's a lot of work. So the next fertility glossaries term is something that I do a lot, just like IUI, so I do a lot of IUIs in my practice. The other thing is IVF, and I think of IVF as is very fun. And I've actually had patients that say, I wanted to go to a doctor who I thought would make this process fun. So when you think about IVF, a lot of people think of like big needles and stress and bloating and pain and lots of symptoms. I'm not going to lie to you. It isn't easy, but at the same time, it's really important that if you are really, really informed about everything, it actually can be a little bit of fun. And it's a huge learning experience. And I'll talk to you about my fertility glossary term for where learning comes from in a second. So the next fertility glossary term is PCOS. So PCOS is a topic that is near and dear to my heart. And I'll post the link for a YouTube show that I did on it in a second. I have a little tickle in my throat. Excuse me. So what I find with PCOS to be extremely frustrating is when a patient comes to me reporting years of irregular periods. The patient might be a little bit on the curvy side, and her doctors have told her this entire time that she has PCOS. without doing any blood work, any types of checks. And the reality is she actually was going through menopause at a very young age. And I unfortunately have seen that not infrequently. So I want to tell you, I want to inform you, I want to empower you that PCOS should really stand for not just polycystic ovary syndrome, but it should stand for please check this ovary syndrome. So when someone gives you a diagnosis, you have to ask, and what is the basis? And let's do some blood work to kind of confirm it, to make sure that you're not missing something else. So when someone has irregular cycles and might be on the curvy side, for me it means you might have too many eggs, or you may not have enough eggs. And there are very simple blood tests that you can do. For example, the AMH test that can be done at any time and kind of guide you in a very quick way. You'll get results back within probably 2 days so that you can have a better idea as to what your diagnosis is. So the next fertility glossary term is TTC, and you guys hear this all the time. I hear people talking about it, trying to conceive, but what I actually think of it as is preparing for pregnancy. And I didn't make this up. I've seen this on Instagram posts, and I've heard a lot of people talking about it, that preparing for pregnancy is actually how we should be thinking about how we approach family planning. I give this analogy, and if you've watched this show, you've heard me say this over and over again. Let's just think about it. If you're planning a safari somewhere, one day I'll go on a safari. I just said safari. Did you get that? So one day I'll go on a safari. I like how that sounds, actually. And what I'm going to do is I'll call my husband and tell him, get me all the information. I probably will. Let's go to the immunization clinic, travel clinic, get all our shots. We'll do our research. We'll get the travel books. We'll read about it. And then we'll go on the trip, right? So why don't we do that with pregnancy? Why don't we get our levels checked? Why don't we get our levels checked before we go on the second trip, which would be a second pregnancy? And if you're really preparing for pregnancy, you're going to do that. You're going to do a preconception visit. You're going to go visit your OB/GYN. You're going to talk about the medications you're on. You're going to see if you should be on vitamins, if you should stop certain medications. I mean, there's certain things that if you did them ahead of time, potentially your trip or your planned pregnancy would go a lot smoother. So rather than thinking of it as trying to conceive, think about it as preparing for pregnancy, and really take that approach so that you have a really good chance of having a successful outcome. And then you can also have the family size that you want. So once you come home with baby number 1, remember that you're preparing for pregnancy for baby number 2. Get your levels checked, do a check-in, talk to your doctor about doing some hormones. And if you used IUI for baby number 1, remember to get that sperm frozen. So patients sometimes send me birth announcements, and I remember, you used IUI and there was a slight sperm issue. Let's freeze sperm now so that for baby number 2, we don't look back and say, we should have had younger, healthier sperm for baby number 2, so we're not struggling or have to do IVF. So the next glossary term is something that people talk about all the time, is IVF failure. And no one wants to think of things as failure. And I have patients who come in with, 700 pages or 1,100 pages of records from their past cycles, and none of them have been successful, and I don't look at them as this is a bunch of failure in this binder. I think of it as this is a bunch of learning for me, so that I can take everything that you've been through and apply it to what we're going to do next. So hopefully whatever we do next will be as successful as possible. So a couple of other ones would be IVF cancellation. So I don't think about cancellation either. So if you heard me at the beginning of the show, I say I'm going to be as aggressive as we can possibly be, and then we'll approach each cycle with everything we have, and then depending on what we learn, if it seems like it's not a good cycle, we're going to revisit maybe doing IUI, but we're going to be closer to our successful IVF cycle. And I don't like the word cancellation because no one wants to talk about failure, no one wants to talk about cancellation. And I certainly don't think of adoption either as failure. So it's really important to think of adoption as another wonderful option. We heard about the story in the news all this week about the embryo donation, and that embryo that was over 20 years old. So if you have unused embryos, the decision to discard them, and once you've done it, it's irreversible. You can never go back and change that decision. Maybe you don't want to donate your embryos now, but maybe in the future it actually might be acceptable to you and your family to do such a thing. So I'm a big proponent of asking more questions. There's no better time to ask questions than now. And so now, meaning at the beginning of your cycle or before you're embarking on your journey to start your family. So ask your questions, see a fertility doctor. You can go to eggwhisperer.com. We can get your levels checked. I can do a review of what you've already done in a really easy way through, telephone, video call, and take advantage of the show. If you have questions after you've watched the show, you can always email at eggwhisperer.com, and I'll always answer your questions either live on the show or behind the scenes. And as always, I want everyone to get ahead of infertility, and I want everyone to think of themselves as super fertile. So thank you for joining me tonight. I hope you'll see me next week, and I'm sure I'll have a really fun show for you guys, and I'll say more fun things like Sepharding. I'll see you guys soon. Bye-bye.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.
Fertility expert Dr. Amy Abazadeh.
And you have yet another success story.
Just launched by an East Bay fertility doctor.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer.